pharmacokinetics. And this is what we have on the board. Majorly, with pharmacokinetics, we are just looking at what? Absorption, distribution, metabolism, and excretion. The mechanism of absorption, distribution, metabolism, and excretion. That's what makes up pharmacokinetics. And all of that will be discussed under the highlighted points on the board. So the first place to start is the route of administration, and under route of administration, we're going to look at what the major routes of administration are: what the enteral routes, the parenteral, and the others. Enteral routes will be any route of administration that does not involve using needle and syringe. So any of those, any route that does not involve needle and syringe will fall under enteral route of administration, and that is majorly oral. So under oral, we're looking at why do we give drugs via this route, because it seems to be the most convenient and the easiest, and it does not require the specialty of a trained professional. You just need to train the person to use the drug, and the person can use that the drug via that, and it can be anywhere. But the problems with enteral will not be, or the oral feeding will not be that if the patient is vomiting, or wants to start vomiting, or the patient is probably unconscious. So because you can ask a person that is required to open his mouth to swallow a drug. So those are some of the limitations with that. And the other limitation is that with oral routes, it might take a longer time before you start seeing the effect of that drug with oral routes. And also, the other thing with enteral routes would be the fact that you may have to use a very, very large dose as compared to other routes of administration. These are some of the advantages or disadvantages of the oral route of administration. Quickly move to the parenteral route of administration, where we look at all the routes, all the methods that involve using needle and syringe. IM, intramuscular, IV, intravenous, IA, intra-arterial. We have subcutaneous, then we have probably intradermal. We also have intrathecal there. That is also intravenous will involve you are directly introducing the drug into the vein. If it is into the artery, we call that one intra-arterial. Subcutaneous, into that subcutaneous layer. Intramuscular, which is the deepest, you are putting the drug into the muscles. So all of these routes of administration, majorly, they would bypass what we call the first pass metabolism. Secondly, some of them, like IV, you will not need to talk about absorption because it is now total. It's not total. So you expect to see that the onset of action is faster, and this needs to be done by a very trained person. Not just anybody can do the parenteral route of administration, and you can use it for unconscious patients or for somebody vomiting or for any reason. But there are reasons why you have to pick a route of administration. We talked about the last one. We said that we have to consider what route is the safest for the drug, which organs are being targeted, which organs do you want to avoid impact, how soon do you want to have what effects, and how long do you want the effect to be. These are some of the reasons that will help you pick up the route of administration to use. And under others, majorly we look at the topical routes of administration, which involve application directly to the skin. Why do we do this? Because we want to reduce the number and quality of side effects, because we want to reduce access to the systemic circulation. So we look at the topical route of administration. There, we also look at routes like probably inhalational route of administration and any other route that you cannot chew on into the enteral or parenteral routes of administration. Sometimes we discuss rectal route as part of the oral route because it is just the other opening of the alimentary canal, while some will discuss it elsewhere. But primarily, we need to discuss the route because the route will affect the processes of absorption, distribution, metabolism, and excretion. From there, we come to absorption of the drugs. What are we looking at on absorption? So, essentially, what we're looking at is mechanism of absorption of drugs from the GIT. Because if you give a drug via the intramuscular route, you have introduced the drug into a muscle, and the drug will be moved out of there based on drug and blood supply to that muscle. So, if you introduce a drug into a muscle or tissue that has a large blood supply, the drug will be cleared quickly into the systemic circulation. So the goal of introducing a drug is for the drug to end up where? In the systemic circulation, and from there that drug can move what? Around the body. So except for maybe topical route of administration where you want to limit access to where? To the systemic circulation. So with this one, mechanism of absorption of drugs from the GIT, we're looking at the mechanism of passive diffusion, facilitated diffusion, active transport, and pinocytosis. So that what is passive diffusion? Here, you're looking at what? The movement of drugs or chemicals in this sense from a region of what? High concentration to a region of low concentration through a semi-permeable membrane. So I would say that this form of transport do not involve a carrier. It does not involve energy. So it happens naturally, and this is the primary way by which most drugs cross from the intestinal lining into the bloodstream by passive diffusion. And most of them might be highly lipophilic. They are highly lipid-soluble drugs. So it's easier for them to move by passive diffusion. The other one is what? The facilitated diffusion. Here, we say that the drugs or the chemicals need a carrier, need something to facilitate their movement from one end to the other. And mostly, they are usually hydrophilic substances or water-soluble substances. So they require a carrier, maybe an aqua pore or a channel. So this is what they require to move across, because they will not readily dissolve they will only move by the cell membrane of the cell. Why is this so? Because we say that the cell membrane is a phospholipid bilayer. It's not just a single layer. We have the outermost layer that's what? Lipid, a lipid layer, the innermost layer that's what? Lipid, and a central layer that is quite aqueous. So a lipid soluble substance can easily dissolve in the lipid layer here and move across, but a water soluble substance will not. So if it is water soluble, it is highly charged, right? So it's that anything that is water soluble has a charge. It is polar. That is the goal. So that is facilitated diffusion that involves a carrier. It moves substances down the concentration gradient, not against it. It does not involve energy. But the point is that at times the carriers can become saturated. Means that probably they get tired, or they get worn out, and it needs some time for them to also recover. So the next way here is the active transport. As I said, active transport involves energy. Here ATP is used. ATP is used is now turned to ADP. So you need energy to make that one work. And for active transport, you can transport against concentration gradients. So you can take something from a very, very low level to a very, very high concentration. So we need that there. Please pause. Transport again. So the active transport is another means of transporting drugs, because we are really talking about drugs here, across the GIT into the system circulation. So all of this we are talking is what? Mechanism of absorption. How a drug can be moved from the site, from the GIT into the bloodstream. So because the GIT is not the site of administration, the drug possibly was administered via the mouth, and so it needs to be absorbed before it can be distributed. So active transport, some drugs will be moved, or some agents will move via action. In this case, there is a requirement of what? Energy. ATP is used up. ATP is used adenosine triphosphate to ADP, adenosine diphosphate. There. And the last one there is pinocytosis, probably for larger substances that cannot cross the cell membrane easily. So what do we have under pinocytosis? We have endocytosis and we have exocytosis. Endo means it is moving into the cell. Exo means it is moving out of the cell. So it involves more like I don't use the word phagocytosis. Like you engulf something up here, then you translocate it from here into here. That is endocytosis. So whether sometimes people they just put their endocytosis there, some will put endo and exo, while some will just put pinocytosis. Involves what? More like how an amoeba would engulf a food substance, put in a vacuum and take it in. So we have a large substance that is taken in from one part across the other. So that substance will not move by any other means of transport. So it requires this method to cross the cell membrane or the tight junctions into the cell separation. Yeah? Looking at the factors influencing absorption, the first thing we talk about here is we said pH. pH. Absorption would occur, we talk whether acidic drugs or basic drugs. So we say that most of the drugs we use are either they are mostly weak acid drugs or weak basic drugs. So in that case, they can easily it will contain the charged form and the uncharged form. So it is the weakly acidic drugs can easily be absorbed in the stomach, whereas the weakly basic drug can easily be absorbed in the intestine because it has that one has an alkaline pH, whereas the stomach has an acidic pH. So the drugs that are the uncharged form of the drug can be absorbed. That is where pH is very necessary. So drugs that have a very, very low pH, like at the exchange, we have difficulty crossing here. Then the blood flow here. So why is blood flow important? Without blood flow, there is no clearance. There's no clearance of the drug. So you are depending, just like oxygen is dependent on blood flow to the lungs. Nutrients is dependent on what? Blood flow to the GIT. Drugs too are also dependent on what? Blood flow to that site of administration, that side of absorption, where they can be taken from there and move off. So there is blood flow involved. Then why do we look at the third surface area? Because for diffusion, since most of these studies are present around diffusion, you need a larger surface area to ensure that diffusion is faster. So that is why the intestine is the major part of the body where diffusion occurs, where absorption occurs rather, because it has a large surface area, and even the villi, microvilli too are large enough to ensure that drugs are easily absorbed across these areas. Then here we look. There is also the contact time and surface. Why is this one necessary? This one is necessary for patients that are probably constipated or have diarrhea. When you have diarrhea, we say the other time is that you have what we call hypermotility of GIT. Hypermotility of GIT means that the food substances or the nutrients or all of those things do not spend enough time in the relevant spaces for them to be absorbed. So as they are just coming in, they are just moving out of the body. So once contact time is reduced, absorption would also reduce. That is the implication. The other thing, the last thing is expression of pig glycoprotein. What are pig glycoprotein? These are some of the organelles you find in a cell that actively export drugs out of the cell. I mentioned mechanism of existence in cancerous cells and possibly microorganisms that at times they actively push out drugs. So it is done by this pig glycoprotein here. So once there is a large expression of this in a cell, that cell will reject itself. It will actively push it out. As it comes in, either by diffusion or it just more like it engulfs it. By exocytosis, it exports it out. That is why they are also necessary. Now, looking at bioavailability here, bioavailability is important when we give a drug via the oral route because the drug will pass through the hepatoportal circulation. Once it's going to the liver, at times the liver destroys some drugs or render them useless or deem them ineffective or harmful to the body. So what the liver does is the liver just find a way to excrete or delete them from the body. So in this case, there is this formula here for determining bioavailability, which is AUC, area under curve, oral, over area under curve, IV, times 100%. So they give those and you plot it. So bioavailability has to do with that. So how do you look at bioavailability? There is the first pass effect or the first pass metabolism that the first time, the time the drug is passing through the liver, the blood flow around the liver or guts. So if the liver deems the drug poisonous or not useful, the drugs are actually metabolized or removed and taken to a point of elimination from the body. So it means that most oral drugs, once they pass through this, the quantity of drug you administered will likely be lower than the quantity that is available in the bloodstream. So this is where bioavailability comes in. We're comparing what is the dose of the drug that was administered and what is the dose or quantity of the drug that gets into the systemic circulation. So it is the dose of that drug that gets into the systemic circulation that is now useful, not the dose of the drug you gave, because of bioavailability. So what we have, the other things that affect bioavailability are things like solubility. How soluble is the drug? Is it fast soluble or is it not fast soluble? We also have chemical stability. Is it stable in acidic pH? Is it stable in gastric pH? So once a drug is not stable in all of this, it will affect the bioavailability of that drug. The last thing is nature of drug formulation, which all of these ones now are from the manufacturer's end. Because the manufacturer determines this and they run their check to see that, okay, would this drug work in a human body or in a body of a human being? Now, the next point here is distribution shortly. Under distribution, we're looking at blood flow here. If there is no blood flow to that organ, the drug cannot be transported into other parts of the body. So whether you're giving the drug oral or using any of the parenteral means, you need blood flow. So if a muscle has low blood flow, it means that the drug you gave into the muscle will stay longer in that muscle. That is the implication. So, because once there is no blood supply to that place, the drug cannot be cleared into the systemic circulation and will not be transported around the body. We also have capillary permeability. This is at the point where the drug needs to cross from the artery, vein, like they need to move across. If they are too small to pass through, so the drugs will likely get stuck in the plasma volume alone, which is about 4 liters. We also have binding to plasma protein and tissue protein, and I thought I'll go over this again. Plasma proteins are proteins found in the blood, plasma. Tissue proteins are found in tissues. These proteins are mains. One of the functions they do is that they bind drugs and other substances. So if a drug is bound to plasma protein, for example, that drug is not a free drug. It is only a free drug that can be taken out of the bloodstream that can exert pharmacological effect. A drug that is bound to plasma protein would only stay longer in the body. That's the point. So plasma protein now, just as treatment, acts as what? A reservoir. It's not like a reservoir. You've taken a drug, the drug is in your body, the drug is not coming out, they are bound to what? Plasma protein. So plasma protein itself doesn't leave the bloodstream. So whereas the drug is bound to that until it is displaced, the drug cannot be distributed, will not be metabolized, neither will it be what? Excreted or eliminated. So those are the functions of the plasma. And majorly here, we're looking at albumin as the plasma protein that is involved in all of this binding here. So we look at also lipophilicity. That is what is the affinity of that drug for the lipid part of the body. If it is highly lipid soluble, it means that that drug will likely cross by passive diffusion, and it may be able to move into other body body compartments. From the first body compartment, which is what? The plasma, which is about 4 liters, we need the drug at times to enter a bigger space. That is what? The ECF. The ECF contains the plasma now, which is about 4 liters of blood in a 70 kg human being, plus the interstitial fluid, which is about 10 liters. So this together makes a total of like 14 liters. So if a drug can cross easily because of its lipid solubility, it can move from the blood and move into this ECF, where it can exert more pharmacological effect on the body. Then it can also move into the intracellular fluid, which is about 28 liters of fluid. So that would mean that the drug will be passing through other biological membranes, other biological barriers in the body. So like the cell membrane, the tight junction, the blood-brain barrier, all those other, maybe the placenta. So the drugs that will move easily through those must be very, very lipid soluble. Water-soluble substances or large molecules will have a hard time crossing. So that is where the lipophilicity of the drug will also affect how in the body spaces a drug can distribute into. Then we have the volume of distribution, which would also concern all the, what I just talked about now, maybe the plasma concentration, the ECF, or the ICF. So the larger the volume of distribution, the more effect the drug will produce, and the longer the drug will stay in the body. I'll repeat that. The larger the volume a drug distributes into, the longer the drug will stay in the body, and the greater the pharmacological effect the drug would have on the body. So if it's staying longer, it means that what? Half-life will be increase. Do you understand it? So because before it gets to those places, it will take time. Before it is moved out, it will also take some more time. So that is where volume. So this is the dose of the drug over the concentration, instant concentration of that drug in plasma. So the effect of the volume of distribution will affect the half-life, as I just said. So if the drug gets into major compartments, the half-life will be longer. I think we talked about digoxin earlier. Digoxin had an half-life of about 36 hours. So that is the half-life. The time it will take for half of the plasma concentration of that drug to be cleared. Not the concentration you administer. So half-life was not a plasma half-life. The time it will take for half of the concentration of that drug to be cleared off. That is that. Now coming to this, we're looking at drug clearance through metabolism, and here we are supposed to quickly go over kinetics of metabolism. What do we do here? Majorly, most drugs will undergo either the first order kinetic or the zero order kinetics. Most drugs will undergo either the first order kinetic or the zero order kinetic. I didn't talk about this before, and I'm saying it now. Now, alcohol, ethanol is an example of a drug that undergo what we call a zero order kinetics. Most drugs will undergo either the first or the zero. What is the difference? In both of these, we're looking at what quantity of the drug was administered. Right? In first order kinetics, a constant fraction of that drug, or percentage is metabolized per time. For first order kinetics, a constant portion or a constant fraction of that drug is metabolized per time. So in first order kinetics, it means that the quantity of drug that is eliminated is actually dependent on the quantity of drug, on the dose of the drug you give. I'll work something out on this to possibly show first order kinetics for you. So when we say a constant fraction, let us say a constant fraction is 10%. 10% is 1 over 10, or that. So if a constant fraction of a drug is metabolized for first order, for example, let's say the drug we gave is 2,000 milligram of, let's say, PCM. So a constant fraction, and I said that per time, it is just what, 10%. So 10%, 1 over 10 of 2,000 milligram will give us what? 200 milligram. So at every time, 200 milligram of this drug will be metabolized. That's what I was saying. So it means that we just need 10 rounds of this. 10 rounds of this to metabolize completely this drug. This is example of how first order kinetic works. Simply, a constant fraction of that drug is metabolized. Now imagine if the dose we gave was actually 20,000 milligram of that drug, and we see how what the 10% of this. So by the time we take 10 out of this one, what liver on the organ would remove will be 2,000 milligrams of that drug. So in first order kinetic, you don't you see how the drug is no much, irrespective of the quantity of drug you took, it still takes around the same time for all of that drug to be metabolized. So 10% of 2,000 is 200 milligrams. 10% of 20,000 is what? 2,000 milligrams. So in 10 cycles, you will metabolize completely all of that drug. Do you get it now? This is how first order kinetics work. This is how first order kinetic works. First order kinetic. How it works simply. But what happened in zero order? In zero order kinetic, it is a constant amount of the drug that is metabolized per time. You may not get the difference. A constant amount. It means that for a 2000 milligram PCM versus a 20,000 milligram PCM. Let us say 500 milligram is metabolized every 30 minutes for Zelda. So after the first 30 minutes, you take away 500 from here, minus 500 milligram. You have what? 1,500 milligram left. After another 30 minutes, you have what? 1,000 milligram. The next one, 500 milligram. This one is 0. So with this one is 0 that because the constant amount, you need like maybe 4 cycles to process 2,000 milligram. Now, what happens to 20 milligram? The same 500 milligram is metabolized. That's where the problem is. So it's not a percentage or a fraction. The same amount. Whether you are giving 10 milligram, you are giving 1,000 milligram. So it means that this one, by the time you do the first time, what should be remaining will be 19,500 milligram. By the second one, you have what? You have 19,000 milligram remaining. By the end of the third one, you have 18,500 milligram remaining. By the end of it, you have what? 18,000 milligram remaining. Whereas, so if you look at this one, first order, a constant fraction or percentage. Whether you've given 10 milligram or you've given 1,000 milligram, it will take roughly the same amount of time to eliminate that drug, whatever the size. But in zero order, you've given different quantities. This one can take 4 half-life, four cycles to complete. This one will probably take in 4 half-life, you still have about 18,000 milligrams. So this drug will stay longer and the effect will persist for long. So one of those that do this is, it can actually, you can drink alcohol and you can have hangover till the next morning, depending on the quantity of alcohol you took. Not just because it is lipid soluble and it can cause the blood-brain barrier, because it takes a longer. There is a quantity the body or the liver will metabolize per time. Once the body does that, it stays. It's not going to increase the quantity to a metabolize because you drank a drum or you drank a brewery. Whatever if the body wants to metabolize a bottle, if you drank a drum, a bottle per time, you drank a whole brewery, you see what? A bottle per time. So for zero order, what you find out is like the effect of that drug might persist because the body can only metabolize a certain quantity of that drug, irrespective of the dose you gave. Do you understand that? So that is for first order and zero order. So in the other part is the phase 1 and phase 2 reaction, still under metabolism of drugs, because I said that what is the goal of metabolism? The goal of metabolism is to render a drug to make a drug ineffective. So a drug will lose its effectiveness. So you are also trying to make the drug more polar. That a very lipophilic drug would become what? Hydrophilic. So that until a drug becomes hydrophilic, it cannot be excreted. So the metabolism is a means to excrete or eliminate a drug from the body. So all the processes are for that same purpose. So in phase 1 reaction, what we have there, we have processes like simple reaction like oxidation, reduction, and hydrolysis. This is what we talk about here. So all these processes are meant to make the drug very polar and less reactive, so it can be sufficiently excreted. If phase 1 reaction does the drug will not need to undergo phase 2 reaction. For some drugs, the drugs undergo conjugation reaction here. Different type of conjugation reaction like sulfation. You add bigger functional groups, which will make it very polar and improbable for that drug to be reabsorbed into the body. So some drugs undergo phase 1, some drugs undergo phase 2, some undergo both. So irrespective, the drug will decide which of these that will occur. And I said before that metabolism does chiefly occur in the liver. It also occurs in tissues too. It occurs majorly in the liver. So you're going to look at the kinetics of metabolism, the reactions, the phase 1 and phase 2 reaction. Then most drugs can either induce an enzyme or inhibit an enzyme. If a drug induces an enzyme, what it does is what? It makes more of that enzyme available, and more of those enzymes would now degrade or metabolize other drugs. So by inducing an enzyme, you will shorten the half-life of other drugs. Whereas by inhibiting an enzyme, you can prolong how long a drug stays in the body. Do you understand this? So this is now in something we're talking about under drug interaction. If I induce it, I have increased what? And I will shorten the half-life of other drugs. If I inhibit an enzyme, I will increase the half-life of other drugs. So this is what we're talking about enzyme inducers and inhibitors. And the major enzyme here involved in metabolism is this family of enzymes called what? Cytochrome P450 enzymes. It's a family of enzymes. You have 4A2, PBD2, 2D6, 1A2, all of them. The drug clearances by the kidney, when elimination of drugs, it will be filtered from in the glomerulus, it will be secreted here. Then some of them might be reabsorbed here or be removed. Excretion. So under excretion, we also have a biliary excretion, we have renal excretion as part of some form of the excretion, and we have other excretion by other routes. Some drugs come out from your water, from your vapor, some from your breath, some are secreted in breast milk, some in bile, some in lungs, and etc. like that. The under note here, we talk about half-life and steady state. I remember saying that usually it takes about 5 half-life to theoretically reach a steady state penetration of the drug. It takes about 4 to 5 half-life of that drug to reach what? A steady state, like more like a fixed concentration of that drug. And this is why we give the loading dose and the maintenance dose. Usually the loading dose is usually about around ×2 of the maintenance dose. You give this so that we can quickly achieve a therapeutic level of that drug. And in maintenance dose, you probably do like half of the loading dose. And this is, I think we should stop here for pharmacokinetics. Thank you.